I'm Amolak. For many years I've been a consultant in immunology and allergy, and my main interest has been in systemic vasculitis and immune deficiency. So conditions that require intensive input, and quite acutely, because these people come in with severe infections or organ damage. But in about the mid-1990s, I became interested in ME because I saw a young man who came in a wheelchair, and I had no idea what was going on. And I investigated him intensively. All his blood tests were completely normal, and I couldn't work out what was going on because I hadn't heard of ME at that point. Because as an immunologist, you wouldn't. In those days, you'll recall that ME was being managed by our friends the psychiatrists. And I suspect they still do get a lot of input into this. But things are changing, and I'll indicate towards the end how they're changing. And if COVID has anything going for it, it's that with long COVID, there has been increased interest in ME, which I now like to refer as a long virus syndrome. So let's get started. What I'm going to talk about is initially just present a brief case, which I'm sure will resonate with a lot of you because it may be how you have presented. And then I'm going to talk about how we diagnose it, what sort of blood tests we do, and then in addition to that, I'll describe a scoring system that I developed a while ago, which I hope GPs can use to allow them to make a firm diagnosis of ME-CFS, which a lot of them struggle with. And then I'll try and indicate what is the difference between the symptoms that you see in people who've got depression and anxiety and people with ME, which I think is very helpful for the GPs because a lot of them are still ascribing ME-CFS as a sort of psychological or psychiatric illness. And we want to get away from that. And then I'm going to talk about what conditions, what may lead on to ME-CFS, how it can be confused with other medical conditions, and then treatment, and some ideas as where the research is going. So that's quite a lot. Usually when I give these talks, it's to other consultants and GPs and the like, and they give me half an hour. I think, bloody hell, I'm not going to be able to say everything in half an hour. So it's always a rush. So it's fantastic that I've got a whole hour. You might not say so at the end. You might think, oh my God, that is just so soporific. Okay, so this is a typical case, but one of the first that I saw. 33-year-old female, corporate lawyer, developed a severe sore throat with fever, glandular enlargement in the neck, headaches and fatigue. You could confuse that with any number of viral infections. And she normally worked 60 hours a week, been very busy with a major client in the previous month, and she'd ended her relationship with her long-term partner some 3 months previously. And she'd been in good health prior to this, and was normally very fit and active, took the pill, but was not on any other medication. And then after a week of feeling awful, she saw her GP, received antibiotics for the sore throat, and she's off for 2 weeks and extremely stressed in relation to her work. And again, that's something we see a lot, that when people develop an illness, a viral illness, a number of different sorts of viral illnesses, often with a background of severe stress going on, and they feel compelled to go back to work. That creates problems with their immune system, which can then lead on to viral persistence, and the whole thing then escalates. But in this lady's case, despite continuing mild fever and headaches, went back to work, exhausted, had to be signed off by her occupational health doctor because she was sweaty and sleeping at her desk. After a further 4 weeks off work, when she tried to do some outstanding case work, as happens frequently, people try and make up for the lost time at work, and she returned to work in a part-time capacity, but 2 weeks later, washed out, needed longer to recover, and now she starts to develop headaches on a daily basis, aching of her muscles and joints, and all aggravated by very minimal mental and physical exertion. And you all know about post-exertional malaise. She felt exhausted, and that's despite sleeping 10 to 12 hours. GP did a lot of blood tests. I'll go through these very, very quickly because they're very helpful. So we check the hemoglobin because we want to make sure there's no anemia. We check the white cell. If it's raised, might indicate an infection going on or something else going on with the hematological system. The ESR, erythrocyte sedimentation rate, is a good test because it tells us if there's chronic immune activation going on. And this is normal, 10 millimeters. CRP, a test of inflammation. If it's elevated, it alerts me and others to the fact that there is something stimulating the immune system. Could be a chronic infection, could be autoimmunity, but in this case it was totally normal. And then the thyroid function test, and I may say a little bit more about thyroid function tests as well. Kidney function, liver function. We do the IgA TTG antibodies to ascertain whether somebody has celiac disease, because I have seen a number of people with gluten sensitivity who present just with chronic fatigue and with minimal bowel upset. And then we do autoimmune profile because there are a number of autoimmune conditions which can present with fatigue and with very subtle signs involving the joints. Now in this lady's case, she started to feel faint on standing, became hypersensitive to bright lights and to moderate sounds. The exhaustion was so severe, she couldn't wash or cook, and she spent virtually all of her waking hours in bed or on the sofa. Her parents became concerned, had some private consultations with infectious disease, diagnosed severe post-viral fatigue syndrome, and then had several further blood tests. Now, I've seen people who've had not only these sort of tests of previous infection, but a whole range of other tests which look at natural killer cells, the different subsets of those. They look at the possibility that there is a subtle viral infection going on. I've seen people spending between 10 and 20,000 pounds on tests. And they are the same as they were at the beginning, and the tests haven't really helped. So I'll say a bit more about what tests may be helpful. And she was advised further rest with vitamin and mineral supplements, but 3 months later, still tired, saw an alternative medicine consultant to arrange tests of mitochondrial and immune function, as I was saying earlier, as well as T-cell-based tests for Lyme and other diseases. Now, that's only £1,200, but as I said, I've seen people who spend a hell of a lot more. And then tests suggested, these tests that she had done suggested impaired energy generation with reduced mitochondrial ATP translocation parameters. Some of you may know about some of these mitochondrial tests. And then she had evidence of Lyme disease with increased interferon gamma produced by lymphocytes. And Lyme disease has become very fashionable, particularly in the UK, chronic Lyme disease as an explanation for chronic fatigue. And if you get time, I may say a little bit more about that, particularly in relation to the tests that are undertaken to diagnose it. Because as an immunologist, I've been very interested in obviously chronic immune activation, polyclonal, what we call polyclonal B cell activation, where the B cells are non-specifically stimulated and they produce a range of antibodies which we say have a low avidity. So they're not specific to an organ, but they will cross-react in many of these tests and give you false positive results. So she received mitochondrial supplements, echinacea, ginseng, plenty of rest, and then prescribed 6 weeks of antibiotics, which made her feel quite nauseated. These antibiotics were like doxycycline for presumed chronic Lyme disease, trying to get rid of the Borrelia. Her fatigue and her symptoms continued, and a further 9 months, she was offered voluntary redundancy package, which she accepted. Her illness continued, but gradually, with the help of parents, she slowly improved and was able to walk for 10 minutes and watch a film at the cinema from start to finish. And the last sentence is particularly pertinent because she lost contact with many of her friends. And as you will recognize, people with ME, when they're really unwell, they can't always meet a particular schedule or timetable, and their friends ultimately give up on them, and they lose a lot of their friends, which really compounds their isolation. Now, when people see their GP with tiredness, okay? It's a shame we don't have other words more precise to diagnose, to help alert the physician as to what you mean by tiredness. You see, there are lots of different sorts of tiredness and fatigue. And so you can see from this, and GPs don't have enough time to do this, neither do physicians in hospital. So when they see somebody who said, oh, look, I feel tired all the time, they don't try to ascertain what they mean by that. Do they mean that you're feeling frail, feeling delicate and vulnerable? Or is there asthenia, muscle weakness and lack of energy? Or a mental sluggishness and lassitude? Or is there inertia? You're unable to initiate an activity. Now, inertia is seen quite a lot in depression, unless you differentiate that. Because people with depression find it very hard to start doing things. People with ME can start things, but they can't finish it. So, have they suffered a general weariness, feeling unduly sleepy? Do they feel unrefreshed, feeling as if they're jet lagged or exhausted with no energy to do anything? And clearly mood will be affected. Are they depressed? So a poor definition of fatigue often leads to a diagnosis of depression or some other sort of psychological problem. And so we need to get a better description of the sort of fatigue that we see in ME. You all know what ME is. Many of you will have had it, or a relative has had it. So, ME, a new onset debilitating fatigue for over 6 months, 4 months in children, with prolonged, delayed worsening by physical, mental, and emotional overexertion, not relieved significantly by rest and sleep, and associated with brain fog. Now, brain fog is one of the worst symptoms. That's what people tell me. They can cope with the tiredness, the physical tiredness, but it's that brain fog which stops them doing things, focusing, that is most debilitating. And so they also have headaches, myalgia meaning muscle aches, arthralgia, sore throats, postural instability, sensory hypersensitivity. And the illness may be precipitated by a number of infections, and I'll go through a little bit of those later on, physical and mental trauma, biochemical and pharmacological agents, and a variety of unknown factors. And one thing we're recognizing more is that people who have joint hypermobility syndrome, Ehlers-Danlos syndrome, particularly type 3, joint hypermobility type, they appear to be predisposed to developing ME-CFS, and we don't quite know why. The condition, as I'm sure you will know, is more frequent in females, with peaks in teenage years, middle age, and it's very likely to be under-recognized in the elderly, because many of them will attribute it to getting old. And the bottom line is very important, because up to now, it has been resistant to a lot of pharmacological agents. So what are the main symptoms? Well, I mean, you know many of these. The brain fog with reduced concentration, headaches, joint aches. With the joint aches, there's no swelling of the joints. There's no synovitis. So I've done a lot of rheumatology as well. I particularly look for the synovitis, and we look for joint stiffness in addition to the joint pain and joint swelling. And myalgia, memory problems, you know about the post-exertion malaise. Quite often it starts many hours after overdoing things physically, mentally, or emotionally, and it can last for days, sometimes weeks. And then there's this hypersensitivity, this intolerance to lights, sound, smells, orthostasis, feeling faint on standing, non-restorative sleep. They go to bed at night feeling tired, they wake up and they're still tired. The sleep has not refreshed them. And then they have sore throats with glands in their neck, occasionally other areas, suggesting some sort of infective trigger causing the glands to become enlarged. Now, when you examine people with ME, there's not a lot to see. As I mentioned, joint hypermobility syndrome, about a fifth, they nearly always have a resting tachycardia, resting fast heart rate. And almost certainly this is due to a combination of factors. Chronically elevated adrenaline and cortisol levels, And chronically elevated adrenaline leads to volume contraction. So the heart is working with a lower circulating blood volume, and in order to maintain the blood pressure and perfusion of the peripheral organs, it beats faster because it's working with a lower blood volume. And the lower circulating blood volume also explains why people, partly explains why people feel faint on standing. And it also explains why their hands and their feet are always cold. And then, this is something that hasn't been written about, something that I've noted for many years. They have altered pupillary reflexes. Now, you may have seen a neurologist and they'll shine a light in your eye, and you've seen it in Casualty and all these dramas about ill people in hospital. So when you shine a light against your eyes, the pupils constrict, okay? Now, and then they'll check the other eye and they'll check the consensual light reflex, etc. What people don't do, what medics and nurses and people don't do, is to continue to illuminate the eye, because they'll check to see the pupil constricts and then they'll take a light away. But if you continue to illuminate the pupil, then it constricts. Now, in people who are otherwise healthy, the pupil then starts, it remains constricted, but in people with ME, a substantial number, the pupil starts to dilate, which is odd, very odd. And in some, it'll dilate, contract, dilate, contract. And we don't know the mechanism, but almost certainly it indicates an imbalance between the sympathetic and the parasympathetic system, suggesting that the sympathetic system is actually working overtime to dilate the pupil. And the abnormally dilated pupil may, to a degree, likely a good degree, explain some of the hypersensitivity you get to light. Because if the pupil is dilated in the presence of even ambient light, it can, for the individual, become uncomfortable because it's just too much. The pupil is abnormally dilated, letting in too much light. Whoops. Now, there's been a lot of research done on ME. A lot of research that was done in the early days used what are called the Holmes and the Fukuda criteria. Now, the problem with that, when you read about some of these old papers, is that the Fukuda criteria didn't require the presence of a delayed post-exertion malaise. So you were mixing up people who had fatigue for other reasons. And that has confused some of the findings that we're seeing. And then the more recent ones, like the Canadian, the ME International Consensus Criteria, and the Institute of Medicine criteria, these take post-exertional malaise into account, and they're very important. So, as I mentioned over there, the Canadian ME and the IOM criteria, they require the presence of the post-exertional neuroimmunologic exhaustion, which is compulsory for these, and it has to be present. And all the research that I've done, everyone who has been involved in this work has had a delayed post-exertion malaise. They have neurological dysfunction with brain fog, chronic pain, non-refreshing sleep. They have problems with their gut and their urinary tracts, and I'll say a little bit more about that because they are ignored largely, and yet, particularly the gastrointestinal dysfunction, may actually hold one of the keys as to why people develop ME in terms of abnormal bacteria in the gut. And then they have impaired energy production, transportation. They have the orthostatic intolerance, temperature dysregulation, problems with their breathing. Now that's very interesting, and I'll mention a little bit more a little bit later. But one of the patterns of breathing that I see very frequently in people with ME is this continuing sighing respiration. So they'll talk about it and then they go, and it's interesting that a lot of people with ME, in addition to that sort of sighing respiration, if you were to measure their breathing rate without them knowing that's what you're doing, you'll find that it is between 10 and 20% higher than individuals who don't have ME. And I'll say why that may be a bit later on. So, what are the exclusion criteria? We know if we use the IOM, the Canadian, and the other criteria, we know how to diagnose it, okay? But what should we exclude? Well, any medical condition associated with fatigue, but there are certain caveats because let's take people who have cancer, okay? We know that cancer can be associated with fatigue, so we exclude them from our study. But once they've had the cancer treated and they're given the all clear, a lot of them are still tired. Now, do they have ME? We just don't know. And then obviously any sort of psychotic, melancholic, or severe depressive illness, dementia, anorexia nervosa. And then that was the original CDC criteria. And then Reeves added a further set of exclusionary criteria. Organ failure, chronic infections, and there's correlation with CRP, ESR, and of course chronic Lyme disease would come into this. So does a person with chronic Lyme disease have ME? No. Even if all their parameters are negative, of inflammation negative, or what do they have? And then you've got rheumatic and chronic inflammatory disease, neurological problems, disease requiring systemic treatment, and then major endocrine disease. Now hypothyroidism, where the thyroid is not working properly, okay, that can cause fatigue, and sometimes it causes fatigue even before the thyroid function tests have become abnormal. And when I see individuals like that who have a lot of the symptoms that we see and the signs of hypothyroidism, I will offer them treatment with low-dose thyroxine, and a reasonable proportion will improve. And then there's primary sleep disorder, but with the sleep disorders, particularly obstructive sleep apnea, even when you treat their obstructive sleep apnea, they still feel tired. So what are we dealing with there? Are we dealing with underlying ME complicated by a coincidental illness? Or what's going on? Or is it that when you develop obstructive sleep apnea, changes occur with the hypooxygenation of the brain during sleep and the snoring? Does that then lead to ME, which then becomes an entity of its own? And as I said below, what about chronic fatigue that persists once the medical or psychiatric condition is treated? So this is my scoring system, which I hope GPs, it's all published, but what it does is to look at all the symptoms that people with ME have, and then to give a weighting to the symptoms that are most characteristic of ME, which you don't see in a lot of the other conditions. And the most characteristic issue is this delayed, prolonged post-exertion malaise after mental and emotional excess. So it doesn't occur immediately as you're doing the activity. Quite often it's delayed many hours, maybe 24 hours, maybe 48 hours or longer. But when it does kick in, it is severe and it is prolonged and very disabling. And then you've got the non-restorative sleep with difficulty getting off to sleep, maintaining sleep, which I think is very important in contributing to the onset of the condition and then aggravating and perpetuating. So that gets a weighting factor of 2, a score of 2, and then you've got all the other symptoms that I've mentioned. They're all given a score of 1. Hang on, this is... Yeah, sorry, it's gone on a few, I was going to say. So, we've got on the scoring system there. So you can get a maximum of 13 out of 13, but you need a score of 8 or more out of 13 to confirm the CFS ME. And with an absolute requirement that people must have this delayed post-exertion malaise in some form or other. Now, in respect to the PEM, which is commonly referred to, as I said, it's got to be delayed over 12 hours, prolonged over 24 hours, and that's why I've weighted it sufficiently. And then there are some further details there, which are all in this paper that I've written. And the fatigue, the neurocognitive problems, the joint and muscle aches, hypersensitivity issues must be significant, and they must cause disability for over 50% of the time. The sleep disturbance and non-restorative sleep impacts significantly on the fatigue, and that's why it's given 2 points. And it must be present 5 or more days per week, and it must persist if people use benzodiazepine and other agents. The difficulty initiating sleep must be longer than 30 minutes, and the waking must occur more than once per night, and they must both be present over 5 days per week. And there are further points about the sore throats, which must last quite a long time and occur at least once a week, and the neurocognitive dysfunction that's present. But you have to take great care when patients have a significant anxiety or depression, because you'll recall that people with a severe unexplained illness, when it goes on this long, will develop a lowering of their mood, and they can become anxious as well. That doesn't negate the presence or the diagnosis of the ME, it just complicates it. And sometimes when these are severe, we have to manage those as well. So we've done a lot of work. My own work in ME has to do with the immune system, and we've looked a lot at the T cells and the B cells, natural killer cells. We've done a lot of work on the cytokines that are released. And if we have time, I'll say a bit more about that. But a huge amount of this has already been published. So here's a point that GPs and a lot of people don't recognize, is that when they consider using the tricyclic agents or the SSRIs, which you'll have heard about, things like citalopram, escitalopram, all those sort of agents, when they are used in people who have ME, you have to start them at a very low dose. If you start them in conventional dosage, then very, very frequently, people with ME will feel really unwell, even with the first tablet. And they feel sufficiently unwell that they'll stop the medication, they won't take it again. So the way to introduce it is about 10% of the normal lowest starting dose, and then gradually build up. The other thing that people with ME tend to develop is this alcohol intolerance. And I've seen people who can't even have a sip of beer or wine without feeling unwell. And we don't know what the mechanism is, but it is something that I use. If I'm a little bit not certain that somebody has ME, you can ask them about alcohol intake. And the people who have it, who have ME, will say they just stop drinking whatsoever because they just can't handle it. And even small amounts will make them feel unwell. So from a clinical perspective, as I said, additional points, because you need 8 out of 13, that may help in suggesting the diagnosis in borderline cases: presence of the cold peripheries, alcohol intolerance and drug hypersensitivity with the altered pupil reflexes and sighing respiration. You add a small amount to those, and that can help you make the diagnosis. What are the conditions that can mimic ME? And there are quite a few. So almost every medical condition is accompanied by fatigue. Persistent fatigue without focal symptoms and signs can be due to disturbance of sleep, chronic pain, inflammation, low mood, anxiety, menopause, etc. So the clinical history is critical. And that's why it takes a long time to interview somebody with ME to make sure we haven't missed any of the other conditions, which are either contributing or perhaps even causative of the chronic fatigue. So when all the routine investigations are normal, think also about the joint hypermobility that I've mentioned. I'm not sure why that is. Think about thyroid autoimmunity. Before even somebody gets abnormal thyroid function tests, Addison's disease, where the adrenal cortex, the adrenal glands, are not producing sufficient cortisol, a steroid hormone, which sort of prepares an individual for stress. And then pituitary problems can contribute to disturbed production of cortisol, and if very advanced, also to growth hormone and thyroid hormone production. Now, Sjogren's syndrome, which I would see because of my role as an immunologist, it's an autoimmune condition which causes damage to the exocrine organs, the ones that produce saliva, tears, that sort of thing. So these people present with dry eyes and dry mouth, except that a lot of people with ME will also have dry eyes and dry mouth. And the reason for the dry eyes and dry mouth is autonomic dysfunction quite often in people with ME, whereas in Sjogren's syndrome, it's due to an autoimmune attack of these exocrine glands. And there are lots of other conditions where the immune system attacks the body and is associated with fatigue. And then persistent anxiety, particularly generalized anxiety disorder and depression, early dementia, Parkinson's disease. I've seen each of these several times in a person who's been referred with chronic fatigue syndrome. And then primary disorders of sleep, obstructive sleep apnea, narcolepsy, and all those. We don't know, and probably a lot of you have heard that if you have an autistic spectrum disorder, then there is a raised frequency of chronic fatigue syndrome. And we don't know why that is occurring. And you probably all know that there has been an increase in the number of referrals for young people with autistic spectrum disorder, ADHD, etc. And we don't know whether that's because we're diagnosing better, new criteria that are being used. We just don't know, except that in both of those conditions, there is an increased frequency of chronic fatigue syndrome. And it may be that both of those, the autistic spectrum disorder and the ADHD, is such a stressful illness. When people don't recognize it, don't sort of give support and advice for it, that the chronic stress can lead to immune dysfunction and autoimmunity and lead to persistence of viruses that have been previously acquired. So I just want to say a little bit about depression and how one differentiates that, how it differs from CFS ME. So with physical exertion in depression, exercise can help. And you know that some of the modern treatments of depression suggest that people go on prolonged walks or do some exercise. Whereas in ME-CFS, if it's introduced without suitable gradation, it can worsen the symptoms. The mood is low in depression. In my experience, it's usually normal in people with ME, unless it's a complicating factor. In depression, there's reduced motivation. The motivation, ME, is normal or raised. People want to do things, they just can't. Sleep, in depression, you get early morning awakening, but difficulty initiating sleep can also be seen, whereas in ME, people find it difficult to sleep because they've got their brains, they're tired but wired quite frequently. They just can't stop thinking. Memory, in depression, there's often rumination about the past and feelings of guilt, whereas in ME, there is word-finding difficulty and precise recollection of recent events. Concentration, normal in depression. In ME, it's impaired, and with extraneous noise and movement, it becomes really bad. Energy levels persistently low in people with depression, whereas in ME, they are variable from day to day, and of course, they have delayed post-exertion malaise. Appetite's low in ME, in depression, whereas in ME, the appetite is normal and the weight is either maintained or sometimes increased. The affect, the way a person appears in depression, it's one of sadness. In ME, it's normal. Quite often, not infrequently, one sees frustration and sometimes anger because we're not getting the right support. And then in depression, interest in outside life is reduced, whereas it's maintained in ME. And the response to antidepressants, in depression, the fatigue may improve, but in my experience with ME-CFS, there is little or no response, even once people have managed to get over the initial hurdle of not becoming hypersensitive to the antidepressant. So I've summarized a lot of these things here, and as I've said, people with ME, they want to do things, they can start them, but they just don't have the energy to finish them. Whereas in depression, they don't want to do anything because of their mood. But if they start them, quite often, they can finish them. ME sufferers rarely resort to alcohol, while some people with depression do. Yeah? So what's the difference between ME versus CFS? I mean, this is something that's been discussed for a while, and also the differentiation between those and long COVID. So ME patients have been considered to have a more consistent and significant post-exertion malaise than those with CFS. Yeah. They also have more neurocognitive dysfunction, and they're more systemically unwell. The fatigue and the other symptoms are more severe, frequent, and prolonged in people with ME compared to CFS. Now, long COVID, or as we would often call it PASC, post-acute sequelae SARS-CoV-2 infection. That shares a lot of the symptoms that we see in ME, in terms of brain fog, post-exertion malaise, non-restorative sleep, muscle aches, etc., etc. Quite not infrequently, the people with long COVID will have an impaired smell because we know that the virus can involve the nasociliary nerves, and it takes a long time, and sometimes they don't have complete recovery of that function. But impaired smell we don't see in people with ME-CFS. Sometimes you can actually get people with ME whose sense of smell is very sensitive. And in fact, I don't know if Vera, did Tom mention it? I've written a book about somebody with ME who develops hypersensitivity of their smell and helps detectives solve crime. Okay, it'll be out in about 2 months. So, measuring physical and mental fatigue. It is difficult, okay, but some of the things that we can do is time how long it takes a person to walk a set distance, and then you can offer the treatment and see how that changes, okay? You can use a pedometer or a smartphone. Time taken to read for mental fatigue, time taken to read 2 to 5 pages, how long it takes them to complete one of these dot-to-dot books, simple arithmetic questions. Now, here is something that I've been working on with some colleagues in Sweden, and it's really, I think it could be very, very interesting. It's really computer voice analysis. Now, computer voice analysis is now used very frequently in interviews, okay? It can also be used to help diagnose depression and anxiety, and I'm absolutely certain that you may be able to use it to diagnose ME over the phone. Because, let's take the case of depression. People with depression have a flat voice, okay? That'll be picked up by the computer voice analysis. Now, people with ME, okay, quite often there is a delay between a question being asked and the person answering it, because it takes time for everything to sort of work through. So that's the first thing you'll see. Second thing you'll see is that they will answer the question, okay, and initially everything's fine. The cadence, up and down, everything, that's all normal. But pretty soon the fatigue sets in. And then you start seeing a worsening of the brain fog, and it takes longer and longer for them to answer the question, and then they stray off point as well because they're not understanding what you're asking. And all that can be picked up on the computer voice analysis. A lot of call centers are using this as well, and insurance companies are using it. It's interesting. But I think it's going to offer a means of helping diagnose it and to monitor people. And this is something I'm going to be involved with my colleagues in Sweden. But we still need new apps to be created to assess mental functioning. There are some available, but they're not very good. And I think the computer voice analysis looks very interesting. Now, if you go on to talk about investigations, I've already mentioned some of those earlier. But the most important thing is you need a full clinical history. The examination, really looking at the throat, tender points, etc., see if there's any fibromyalgia, look for joint hypermobility syndrome. But at the very least, your GP should check your full blood count, the hemoglobin and white cell count, the ESR, tests of inflammation like the CRP, check your kidney and liver function, look at your thyroid, also check your iron levels, because both high and low levels are important. People who have raised iron levels as part of hemochromatosis, and I occasionally get referred these people as well, they have an abnormal protein that increases iron absorption, and so their ferritin and iron levels are very high, and they can feel tired because of a different set of reasons, and they also develop joint pains, and they've got a predisposition to developing diabetes, etc. But the mechanism of fatigue in hemochromatosis is different, and even when you reduce their levels, a substantial proportion will not improve. And as I mentioned earlier, we need to check for autoimmunity, check for celiac disease. As an immunologist, I would check a person's immunoglobulins because amongst the people that I used to treat with antibody deficiency and T-cell problems, etc., there is a very high frequency of chronic fatigue. You will know that CFS affects about 0.25 to 0.5% of the population. Amongst my patients with antibody deficiency, it's as high as 30 to 40%. Very, very much higher, suggesting that if your immune system is not working properly, then you may be allowing some of the infections, the viruses that cause ME to reactivate and contribute to the fatigue. Vitamin D level, everyone measures those these days, and the vast majority of people have low levels. But when you treat the low levels, it doesn't make any difference to the fatigue. I haven't really seen anybody who said, oh, my vitamin D level is low, I was offered treatment, and I improved back to normal health. Never seen that. Take them anyway, might prevent osteoporosis and other problems. And then there are further investigations directed by the clinical history. We can home in on any autoimmune problems with anti-nuclear antibody assessments, etc., ENA, DNA, rheumatoid factors. If there's a lot of muscle tenderness, we want to look for raised muscle enzymes, perhaps do an EMG where we measure the electrical activity of the muscles. If there's widespread aches in older women, check for osteoporosis, do a DEXA scan. And if there's any suggestion of Addison's disease or Cushing's, then a synacthin or dexamethasone suppression test. I don't often do tests looking at previous viral infection of Lyme disease because we don't really have a lot of treatment. But again, I'll say a little bit more about some of the work on the viruses that can cause ME-CFS. Not only Epstein-Barr virus, which you'll all remember causes glandular fever virus, but there's a lot of work now going on HHV6, human herpes virus 6 and 7, and some of the, what we call HERVs, the HERVs, the human endogenous retroviruses, particularly HERV-K. And on rare occasions, I might do some of those tests as well. And then you've got neurological abnormality. Probably doing an ordinary MRI will be reassuring for the person who's got lots of headaches and fatigue. They haven't got a brain tumor or normal pressure hydrocephalus or benign intracranial hypertension. It can be sort of helpful in those ways. We won't often do in the routine clinic any functional tests of brain perfusion. Major sleep studies, yep, order those not infrequently, and then ECG and echocardiograms as necessary. Tilt table testing becoming more frequently requested because of POTS, which you all know is highly related to ME-CFS. And then 24-hour ambulatory ECG monitoring. A lot of people with ME will have these palpitations and the heart really goes like craplers. And there I would do an echo and do the 24-hour ECG monitoring, make sure there's no arrhythmia going on. And then some of you will know about problems with the cervical spine, atlantoaxial instability. And a few years ago, there was a real interest that problems with the upper cervical spine, neck, this instability of the top two vertebrae balancing with the neck. So if you have problems there, that can contribute to the headache, cause autonomic dysfunction, and contribute to the fatigue in a way that wasn't completely understood. And then there were some Spanish neurosurgeons who reported their very, very brief experience of treating this atlantoaxial instability surgically, and they said, yes, it can make a substantial improvement. But in fact, I mean, with continued monitoring these people, it looks like the improvement is not nearly as significant and not nearly as frequent. And in my experience, I would advise people to be very careful. Going for surgery is such a delicate part of the body. And then we've got neuropsychological testing and a whole sort of other treatments, investigations that I will perform very rarely. So what about triggering infections? Well, you've heard me mention about the herpes viruses, EBV, cytomegalovirus, HHV6, 7. Viral hepatitis can also cause fatigue. Influenza, people will say that their ME followed on from an influenza virus. Enteroviruses were all the rage prior to the recognition of HHV 6, 7, EBV, and people were thinking, was ME-CFS a type of latent polio or echovirus infection? That sort of idea is gaining a little bit more interest of late because some of the molecular tests that can be done. But parvovirus still remains a possibility in Africa, Ebola, SARS, MERS, and other viruses. But the common cold, very rarely involved. COVID-19 I've already mentioned. And remember that chronic fatigue may occur in about a third of people 3 to 6 months post-COVID, but then it declines. 10% by 12 months, and it declines further. And there are various bacterial infections that can cause it. Lyme disease caused by spirochete, not a bacteria, Borrelia species, and then toxoplasmosis. Now, you probably may know some people who say that their ME may have been caused by exposure to moldy homes or workplaces. But in fact, there's very little evidence in regard to the role of Candida, whereas mycotoxins, that is occasionally mentioned as a cause of ME, and there's a condition called chronic immune reactive syndrome in which it is suggested that mycotoxins may be the cause of fatigue. But finding the elevated levels of mycotoxins and trying to reduce them with reducing exposure to any sort of moldy homes and things doesn't really lead to a reduction in the symptoms in my experience. And I've seen people who have had these urinary tests performed, urinary mycotoxins, the levels are elevated. They've got companies come in to get rid of even the slightest bit of mold in there and dampness in their home. And they spend 10, 20, 30,000 pounds, but without any improvement. So it's just something to bear in mind, but my experience, very rarely has it ever provided benefit. So immunizations, contentious, and there are some rare anecdotal reports. I mentioned earlier that whenever we're thinking about these various other infections, we have to be careful about this condition of polyclonal B-cell activation, because we know that the Epstein-Barr virus and a lot of other viruses can non-specifically stimulate your B cells to produce antibodies which are not specific, but yet when you test them in an assay, they'll give these false positive results, suggesting that you might have had infection, not only with a lot of the, like Lyme disease, but also with Bartonella, babesiosis, and a range of other conditions. Now, this diagram I think is very important. And what it shows is that when you have established ME-CFS right in the middle, there are a number of things that can perpetuate the condition and aggravate it on a daily basis. And they're all linked to a good degree, and you can see how the arrow's linked. But stress is very important, and the stress can be physical, mental, emotional. It can be infective as well, so that if you develop a cold or a virus infection and you've got CFS, then your symptoms are much worse. Yeah? And we know that with chronic stress, there is an increased amount of adrenaline release, increased amount of cortisol, and a number of neuropeptides, all of which have an adverse effect on your sleep and on your immune system and the endocrine system. And stress can certainly impair the immune systems to keep chronic herpes-type viruses like Epstein-Barr virus, HHV6, HHV7. If it's disturbed, those viruses will reactivate, and they have a very negative impact on your immune system and also on your sleep and on muscle function and gastrointestinal function as well. So all these factors will impair the ability of a person with ME to recover, and they will certainly perpetuate the condition so it becomes long-term. So when I manage people with ME, okay, I frequently see treatment being offered, let's say, for stress or for disturbed sleep or gut function. Now you can see why, when you want to treat people with ME, you have to address all these factors at once. Yeah? So that is why my clinic, and I would have to say now I've been seeing people with ME 25, 30 years, and I must have seen between 8,000 and 10,000 people with it. So when I see the people, I offer many treatments looking at all these areas at once, okay? Because if you don't do that, you offer treatment in one area, it doesn't work, people lose hope, and they're saying, well, it's not working. That's because all the other areas are still dysfunctional. And then, I mentioned earlier that one of the main problems that people with ME have, and which causes such a profound disability, is the cognitive dysfunction, okay? The brain fog. And this diagram sort of indicates how it occurs. And I've written a couple of papers recently indicating what may be causing this impaired function of the brain, that people can't concentrate, they can't remember. And it's a very complex issue, but a lot of the neuroimaging studies have provided information in terms of reduced perfusion of critical areas of the brain, due either to something we call an endotheliopathy, where the lining cells of blood vessels become activated and they slow the flow of blood down. And then we've got dysfunction in what we call the reticular activating system in the brain stem. This is the filtering mechanism of the brain, okay? So you've got stimuli getting to the brain from your eyes, your hearing, smell, taste, your various receptors in your muscles and joints and in your skin. Okay. In order to concentrate on something, the filtering mechanism in the brainstem has to be working, okay, so that you can focus just on one thing. If you don't, you will be feeling, and your brain will be bombarded by all the stimuli from all your sensory organs that you can't concentrate. And if you can't concentrate, you can't remember, okay? And so that partly explains why people have this brain fog, in that the filtering mechanism is reduced. And we know that the volume of structures within the brainstem, when we do our imaging studies, are reduced. And I've also talked about disturbed sleep, leading to neural loss, dysfunction. Sleep is critical to the way that your brain works. It's critical to normal energy levels as well. If you don't get proper restful sleep that goes through the various phases, and remember that these phases of sleep are repeated several times in each sleep cycle. So if you don't follow the normal sort of phase 1, phase 2, phase 3, 4 sleep several times a night, then your sleep is not restorative. And during sleep, we think, well, during sleep, the body's resting, muscles are resting. But in fact, during sleep, a lot of amazing things happen. One of which is the way that memory is laid down, okay? And then during sleep, we get remodeling of the dendrites. These are the little projections from the various cells, and they're modified, okay? And we also know that that is critical for memory function. But there are other changes that occur in what we call the limbic system and the hypothalamus and thalamus. So what about therapy? Now, so you all know about talking, walking therapy and supplements. We know that pacing, deep relaxation, meditation, breathing control are very important. In fact, a lot of people don't do breathing control, which I do suggest they do. I've already mentioned that people with ME have a faster respiratory rate than everybody else. So it is important to control that. Now, cognitive behavior therapy was all the rage, as you know, before. Thankfully, somebody suggested that we don't use it routinely because, and I don't routinely use it, but I do use it in selected cases where there's a lot of anxiety or hypervigilance or catastrophizing, okay? But I do not use it routinely at all. And graded exercise therapy, I've never used that from the beginning, because why, if somebody's tired and exhausted and has delayed post-exertion malaise, would you force them to go on doing things which we know is going to make things worse? What I do suggest is that they keep their muscles working. And the reason for that is that when you use your muscles, you are stimulating the production of brain-derived neurotrophic factor. Now, BDNF is very important for nerve cell regeneration, okay? In fact, functioning muscle also releases a variety of endorphins, which elevate the mood, which is why runners get this high after running, yeah? And it's also helped reduce pain, these endorphins. I also use a lot of vitamin B12 because B12 can stimulate antiviral pathways, and it can help reduce neuron loss within the central nervous system, and various other things as well. There are these muscle tonics, magnesium, L-carnitine. They can be helpful, but nearly always I would use not just one, but several of them to try and optimize mitochondrial ATP energy production. It's interesting that coenzyme Q10 is now being used by a lot of cardiologists for people with heart failure, and in doses which are very high. I mean, we would normally have suggested 30 milligrams, but the cardiologists are using something like 300 milligrams a day. Yeah? And it does help. And then the work on gut dysbiosis, abnormal bacteria in the gut. I've been involved with this with colleagues in the University of East Anglia, at the Quadram Institute, and there is gut dysbiosis going on. Whether that is the primary cause of ME-CFS, we're not certain, because if you get an abnormal gut population, you will get sort of a leakiness of the bowel epithelium, so it absorbs some of these amino acids, and lots of these amino acids, particularly glutamine, are also neurotransmitters. And so when they go to the brain, they can cause an abnormal pattern of stimulation. And also there's work on production of things like butyrate, which the brain can use as energy substrate. There are lots of medical treatments. You'll know that your GPs are very reluctant to provide many of these, okay? And if they do, there are off-label treatment. However, they will have use SSRIs or tricyclic agents, that sort of thing, that's fine. And if there's depression going on, then yes, go ahead and use them. Benzodiazepines for sleep were used in the past and for anxiety. It's very hard for GPs to prescribe these now because of the possibility of dependence. But they are still useful in some people. For sleep disturbance, I now recommend the use of what I call one of the dual orexin receptor antagonists, particularly daridorexant. Okay? Now, that has little ability to cause dependence, and it doesn't cause daytime drowsiness, whereas a lot of the benzodiazepines like nitrazepam, temazepam, they can do. So these are pretty good. And there have been some people who have been transformed because they're now getting a good night's sleep, which is restorative. The GABA agonists, you will know, things like pregabalin, gabapentin, all those sort of things, they can be helpful, okay? Particularly for fibromyalgia. But in my opinion, low-dose naltrexone, which is sort of third from the bottom, that is more helpful for fibromyalgia. And low-dose naltrexone can also help the fatigue. I would also use things like, very rarely I'd use modafinil because, again, GPs are reluctant to provide it. It can help mental fatigue and improving attention, but I'd use it cautiously. I wouldn't use it every day. What I might do is offer it to somebody, say, look, when you want to go and visit your bank manager or your employer or something, take it an hour beforehand, and it just helps you focus a little bit more. Pyridostigmine, which is an anticholinesterase inhibitor, that can help the muscle fatigue and gastrointestinal problems. Nimodipine is a calcium channel antagonist. It was used in the past for people with subarachnoid hemorrhage because what it does is to relax the blood vessels, the smooth muscle in the blood vessels. Because after a subarachnoid hemorrhage, there is spasm of these vessels, which makes the brain injury much worse after the hemorrhage. But in the case of people with ME, we think that there is an element of constriction of some of the vessels that supply the brain. So using the nimodipine allows those to relax, and in some people it can help improve their brain fog. The thing that which I really find helpful is low-dose aripiprazole or Abilify. I don't know whether many of you've heard of it. Okay. It's a dopamine type 2 receptor partial agonist. Okay. And it was used principally, and it's still used principally in people with schizophrenia. It's also used in autism, by the way. Okay. In schizophrenia, we would use probably 20 to 30 milligrams. And low-dose aripiprazole is between 1 and 2 milligrams. The dose is way lower, okay? And when introduced cautiously, starting at 0.1 milligram a day, daily for a week, and increased by 0.1 milligram every week, then it's very well tolerated. And I have some people whose lives have been totally transformed by it. There have been no double-blind controlled trials done of many of these therapies, unfortunately. So I keep a careful eye on the individuals in whom I use these, and I make a note of those who benefit and those who don't. And in my experience, the LDA, the low-dose aripiprazole, does appear to provide benefit in a reasonable proportion of people, and with very, very few side effects. And then melatonin you use for sleep. I use low-dose thyroxine. Very hard to use growth hormone because it's so expensive, and hardly any GPs will prescribe it. Steroids, glucocorticoids, GC, occasionally I will use them. If you give a person with ME a significant dose of prednisolone and steroids, I can guarantee that they'll feel better, but they'll only feel better for about a week, and then they say, oh, I'm back to where I was, I need a bigger dose. And if you start to escalate that dose, you know what side effects can occur from long-term high-dose steroids, and it's just not worth using it. But occasionally, very, very occasionally, I might consider it. And then antivirals. I mean, I would use acyclovir and valcyclovir very frequently. Now, the reason for doing that is that the role of herpes viruses is gaining more attention, okay? And it's not that there's one herpes virus doing it, there are several, okay? A polyherpes virus infection. So HHV6, V7, EBV, frequently involved. But there's some interesting work suggesting that even the chickenpox virus, herpes zoster, may be showing subtle signs of reactivation. And certainly things like acyclovir and valcyclovir can suppress those. Now, the reason for doing that is that many of these herpes viruses will produce a protein called DUTPase. Now, that can have an adverse effect on mitochondria in terms of energy production. So if you can try and reduce the activity of these viruses, you can encourage the mitochondria to produce more energy. So it's very interesting, and I use acyclovir and valcyclovir a lot, exceptionally well tolerated. And I would use them for 6 months, sometimes for 3-4 years. Low-dose doxycycline, I would use that occasionally, not because I think people have got Lyme disease or something, but doxycycline is actually a very good anti-inflammatory agent. It can reduce the production, particularly of tumor necrosis factor alpha. I haven't used Ampligen because it's very expensive, but we know these are strings of nucleotides which stimulate the antiviral pathways via a particular receptor, the TLR3. Inosine Pranabex can stimulate T and NK cell activity. I've used that a fair amount, very well tolerated. Amantadine, which is originally used in people with Parkinson's, that too can be helpful, and it stimulates the release of dopamine, which in some people can be helpful, particularly obviously in Parkinson's, but it also promotes antiviral activity. Immunoglobulin is very hard to get hold of. It's so expensive, costing between 20 and 40,000 pounds a year. We just could not use it in people with ME. I mean, nobody would support it, although there is some work that it can be helpful. And then anti-B cell therapy, you remember all that work coming from the Nordic group. Rituximab really helps people. That, unfortunately, in the prolonged follow-up did not show any benefit. They're now experimenting with using cyclophosphamide, which has the ability to wipe out a lot of lymphocytes, and we're not quite sure how it works. And now the most recent thing is rapamycin, sirolimus. There was a trial, the sirolimus trial. I don't know if any of you read about it, but rapamycin is a drug that I've used reasonably often in people with systemic connective tissue disorders. And then there's a big literature on using rapamycin at about 5-6 milligrams per week as an anti-aging drug. And there are hundreds of thousands of people around the world who are using it to stop them aging fast. And it's all related to this autophagy. Now, autophagy is sort of a cell housekeeping function. So damaged proteins, damaged organelles are then put into a special vessel and then degraded, and the proteins and the amino acids are produced and then recycled. And if you can improve this using rapamycin, you can reduce aging. But in the case of ME, we think there is impaired autophagy going on, particularly in relation to mitochondria. And if you can reduce mitochondrial damage or recirculate them, then you will see benefit. Some latest thought. I think this is the last slide. I know you need coffee, I'm sure. Okay, so GDF15, growth differentiation factor. This is the mitokine and produced in response to stress. But the thing is, it can communicate with the brain to indicate the need to rest. Okay? And it's presently serum GDF15 levels are used to differentiate the mitochondrial myopathies from various other sorts of muscle disorders. It's interesting that mitochondria can also produce cortisol, which is a steroid hormone, and that can disturb energy production. And it can also alter the mental perception of being unwell. Finally, we are trying to repurpose certain drugs, particularly those like saxagliptin, vildagliptin, which are DPP4, dipeptidyl peptidase 4 inhibitors, and they can address the potential muscle dysfunction that's present in people, metabolic dysfunction that's present in people with ME, but they also have the ability to reduce inflammation and autoimmunity. So, last slide. I hope you will take some comfort from this. So when we do, I recently did an AI view of ME-CFS, and this is what's sort of coming up now, that it is really firmly established that it's a physical, often post-infectious disease with significant immune and neurological dysregulation, and it's moving away from a psychological interpretation of the illness. And for that, we can partly thank COVID-19. I'll leave it at that, and we'll take questions. There's a lot to take in, I'm afraid. Yes?
I had ME for nearly 20 years, and I lose time, and I'm wondering, have you come across that?
Oh, very frequently. Oh, absolutely, yes. The concept of not being able to measure how time goes on is in part related to impaired attention and memory, okay? And it's very frequent. I mean, I see people in my clinic and they'll say, oh, when did I last see you? Oh, was it as long ago as 6 months? I thought it was a few weeks ago. It just happens very, very frequently.
It has happened when I'm driving, and I don't like to drive for distances. But I still been able to drive, which amazing.
Yeah, absolutely. So some of the driving functions are automatic, okay? They bypass the neuroprocessing. You've just done it so often that you just do it. But a lot of people with ME do find driving difficult, as you probably do, because of the movement, having to take into account everything that's happening on all sides. It overwhelms the sensory pathways, and this filtering function of the reticular activating system in the brainstem is impaired, and it's very hard to focus when everything is bombarding you.
Would you have any recommendations like that are no-brainers in terms of diet that people with ME should be doing, and particularly if
Okay.
leaky gut is suspected?
Particularly what is?
Leaky gut or...
Yeah, okay. Now, the work on leaky gut, it is interesting because there is some suggestion that the colonic epithelium, and to a certain degree the small bowel epithelium, is dysfunction and allowing the absorption of partially digested proteins, amino acids, and a variety of compounds secreted by bacteria, fungi, and viruses and bacteriophages as well. And when these are absorbed, they contribute to the overall symptoms. How to reverse the leaky gut, okay. We previously thought that if you corrected the bacterial population, that would do it, but that's not the case. The role of viruses is very important, and particularly something called bacteriophages that control the bacterial population. Okay, so it is much, much more complex than we ever thought, and trying to correct a leaky bowel just by taking probiotics is probably a little bit simplistic. However, having said that, okay, we are doing a trial, my colleagues are doing a trial on FMT, which you probably heard about, fecal microbiome transplantation, okay? And we will know the result probably in a couple of years, but there was an Australian group that used FMT and found it helpful, okay? That is, they took the bacterial population of a healthy person and then transplanted in somebody who's got, in their case, IBS, but sometimes with CFS ME as well. And it can prove helpful, but we don't know how it's helping. Is it reducing the leakage, i.e. the leaky gut, or is it altering the bacterial population so it's producing, let's say, normal amounts of butyrate and other compounds, reducing the amount of stimulatory neuropeptides and glutamine that are produced? We just don't know how it's working yet. So recommendations for treatment. If you're going to use probiotics, don't just use one. What I say is start off with one, change to a second different one a week later, a third, fourth, fifth, sixth, seventh, go back to number one and rotate them. Because taking just one probiotic, I've never seen to work.
Is that in terms of supplements or, from
just the probiotics, okay. In terms of the supplements, do you mean...
like a pill that you would take, a tablet?
What, containing oligosaccharides or fructosaccharides? I wouldn't, they might help to agree, but quite a few of them are expensive. I would just stick to the probiotics, yeah. When we were in a particular trial, we would try and introduce the probiotics. Firstly, if we're going to do it orally, we would suppress stomach acid production. And if we're going to go through the other route, then we would try and empty the gut first using a series of laxatives to give room for the new bacteria to sort of get hold. But anyway, watch this space. I think there are interesting developments occurring in this field, but almost certainly it won't just be the bacterial population. We just don't quite understand the fantastic role that these bacteriophages are having on controlling the bacterial population and also other populations as well.
But you would recommend a diet of varied probiotics?
I would definitely, but in my opinion, the most important thing in terms of dietary management, apart from perhaps suggesting reducing the amount of wheat, because we know wheat contains gluten, contains gliadin, all these sort of beginning things lead to an increased glutamine production, which can make people feel more tired, more edgy, etc. The only thing I recommend is that when you're eating your food, you really enjoy it. Okay? That is we underestimate the adverse effect of eating something and thinking, is this going to make me unwell? Okay? Because that creates a stress of its own. You're going to eat the foods you enjoy, and when you're eating them, don't think about your ME, just really enjoy the food, the taste, the flavors and things. Yeah?
Similar question to your last point was on modulation of autophagy.
Of what, sorry?
Autophagy.
Autophagy, yes.
Autophagy. that can also be caused by fasting,
Oh, absolutely.
limiting
Yeah.
diet, intermittent fasting. Any
Definitely.
knowledge of how this could help? Or?
Well, okay. People who fast, particularly for 14 hours plus, there is some evidence that they don't age as fast. You've probably read all this, and that's okay. And the Paleolithic diet and all those where you don't eat as much and you eat sort of the foods that we used to eat, they may also be helping in that respect. But with autophagy, we know that stress has a negative impact on that. And you're right, fasting does as well. But there are a host of other factors that also impact on this. Several viruses and several infections will impact on this. And trying to remove those is very important. But in terms of the sirolimus trial and the using the rapamycin, at the moment, there is only one open label study, so it's not double blind, okay? And they use doses between 5 to 6 milligrams a week. And they found that this was helpful in people who knew they were taking sirolimus, open label study. There was nothing to compare with a placebo, and it wasn't blinded. So I think we've had a lot of false starts in this sort of work. And I remember many years ago, there was a particular treatment involving an antiviral agent, and Roche was the company who sponsored this. And it led to an improvement in 90% of people in an open label study. And then they repeated it in a double blind study, and there was no difference from the placebo. So we will wait to see, but it looks interesting, I think. Brilliant. Oh, yes, sorry.
What strength LDN? I have a few questions.
Yeah.
What strength LDN would you recommend?
Okay, I mean, most people use a top dose about 4.5 milligrams a day.
4.5.
The naltrexone tablets from which it's derived come at 50 milligrams. There is the pharmacy in Glasgow, Dixon's. Well, they will, they're very good actually, very good indeed. I mean, they will produce a liquid version, okay? And I always recommend that people start at a low dose and then gradually increase, okay?
I'm on 3 at the moment.
You're on 3, yeah, go up to 4.5. I've seen people who've only benefited when they got to 6 or 7 milligrams, but I wouldn't go much higher. Partly because it becomes more expensive, and if you're not going to respond at sort of 4.5, 5, 6, you're not going to respond at 10. Yeah?
That makes sense. And in terms of, like, I'm getting kind of annoyed with my consultant and my GP at the moment.
Yes.
Recently, my consultant has recommended CBT. Now, I've done CBT years ago, so I know what's for. Why are they recommended CBT for people with ME?
I just don't know.
I think it's all in your head.
I haven't recommended it, so it's very hard for me to work out why in a person with established ME who doesn't appear to be depressed, anxious, who doesn't sort of monitor his health 24 hours a day with Fitbit, heart rate monitoring, whatever.
Like as I said, I've done CBT. Like it's to retrain your brain and the way you're thinking and the way you're interacting with people. But it takes a lot of energy.
It does.
For CBT, like just from my own experience.
Yeah, absolutely. And I would have to say, in my clinic, because I tend to see people after they've done everything, the numbers you've said, CBT has made a profound difference, and very, very few.
Yeah.
And that's after seeing several thousand. Yeah. It can help if you have hypervigilance, where you're constantly monitoring your health, as it were. Am I feeling a bit tired? Better stop what I'm doing because it's going to make me unwell. Or if you're catastrophizing, I can walk for 5 minutes, but if I walk 5 minutes and 1 second, I'm going to be laid up. Those sort of things. If you can correct those, it's helpful there. But otherwise,
yeah. And they've also recently recommended GET therapy that you recommend. Yeah, it's like they're kind of in the past or something.
I know they've obviously haven't read.
But after your presentation there, that has taken a lot out of me. Like, right, think if I go back to work at the moment, I just go to the complete.
Yeah, I'm not sure why they're recommending those two therapies when we know that the NICE guidelines have changed.
Yeah.
The UK NICE guidelines, and they're not being recommended.
Is there any rheumatologist in Dublin that you know is good? That could be putting you on the spot.
I don't know any rheumatologists in Dublin, I'm afraid. But one thing I would say is, look, keep the muscle strong and active, because muscle tissue is a major source of this BDNF, the brain-derived neurotrophic factor, okay? And using the muscle stimulates that, plus the endorphins, okay? And of course, there's this thing about deconditioning, etc. But I recommend keeping the muscle strong because of these very important hormones, yeah? And particularly for mental function, concentration, memory, the BDNF is important.
Yeah. Thank you.
Yeah.
Sorry, another question. Have you come across anyone with ME who also has developed Sjogren's syndrome?
Sjogren's? Oh, yeah, yeah. Okay.
Do they get more tired or just stays the same?
Okay, Sjogren's syndrome, as I mentioned, is an autoimmune exocrinopathy involving, okay. We're not quite sure why fatigue is such a major problem in Sjogren's. It affects over 90% of the people, and quite often it can be the most disabling of the symptoms, more so than the dry eyes and the dry mouth, but we don't know why. There is some work suggesting, and I've seen this only once because I've managed people with Sjogren. If you use something like hydroxychloroquine, okay, that can slightly help that, okay? But there's very little that works for treating the fatigue in Sjogren's syndrome. Sometimes some of the immune modulatory therapies can be helpful, but we wouldn't often use immune modulatory therapies in Sjogren if it is just the problem with the dry eyes and the dry mouth, and perhaps the joint pains that they can be managed by other means. Hello.
I just had a question in relation to stress.
Stress.
I'm someone who, you know, it's periods of non-stress, I'm almost back at normal health, I'm not even on medication all as well. If I go through a period of stress, everything will sink down.
Yes.
And my question is something like, in terms of managing something like that, I mean, obviously, you know, I know there's things to manage stress, and I'm on that as much as I
Sure.
can be. Is this a sort of situation where it would be worth, for example, increasing one's standard ME-CFS medication to prepare for a period of stress?
Interesting.
Or is it more that you need to respond to that
Okay.
once the stress is
I personally would not increase the supplements and everything to prepare you for stress. What I would suggest is resting more, and also using the controlled breathing. That I think can be very helpful. And because you're aware that stress has such a negative impact, any other therapies that you want to use, like meditation or yoga or qigong or...
I do almost all of the above, but yeah, I agree with you, they're helpful.
Yeah.
Yeah.
Yes. Are there any anxiolytics that could be used? On very rare occasions, a small dose of a benzodiazepine that can be helpful. If you wanted to reduce the stress, the anxiety associated more long term, then a low dose SSRI can be helpful. I wouldn't use any of the other things like olanzapine, etc. Very difficult to manage. Yeah.
There have been quite a number of countries that have legalized cannabis over the past 10 years. And is there any evidence that has helped any sufferers in those countries?
I have seen a few people who use cannabis. It's much more frequently used in people who have MS, I have to say. But in ME, I haven't seen many people use it to combat the fatigue. They have used it to help the pain if they've got associated fibromyalgia, and sometimes it can help them sleep. But in terms of combating fatigue, I haven't found it especially helpful.
Regards the pupils,
Yes.
My youngest finds that sometimes one pupil is more dilated than the other.
Is that
He's
right?
really worried about it because we have
How long has it
had
been going
doctors
on?
check it a long time, like
Okay.
a number of years.
Okay. That is weird.
Yeah.
Because a unilateral pupillary abnormality, as you know, has connotations with
Yeah.
obstruction or damage to the visual pathways along the opposite, the same hemisphere. Yeah. If it's been going on for many years, I'd ignore it.
An uncle has had a brain tumor, passed away.
So I presume that a brain scan has been done.
Yeah, but it's still ongoing, and so there's a concern.
Yes, I mean, if it's been going for a long time,
Yeah.
then I can't explain why that would occur. And presumably a neurologist has looked at the visual pathways and they don't think anything's going on.
There's been hardly a referral to anybody. It's all like it's in your mind.
And-
It's
and-
not down.
Sure. Any headaches?
Yeah. A lot of headaches, like hours long, just won't take medication for headaches.
Well, in that case, I think there is definitely reason to get a neurological input.
Okay. We have moved doctor recently, and it's been shown that their antibodies, although normal at the very lowest level. So there's
Antibodies to what?
just general antibodies in the system. you
What,
know.
the overall IgG level?
Overall IgG level is within the normal range, but extremely at the lowest end.
Okay,
So
I mean, that would need
that-
monitoring because, how old is the person?
It's going on from age 12 and now 27.
Okay.
It's very severe at the moment, really severe for the last few months.
Okay. I have seen a similar case once before
Yeah.
where the antibody levels, overall antibody levels, have declined over a period of many years. And the reason for starting the immunoglobulin replacement therapy there was that they started to develop recurrent chest infections. Okay? And when we did start, we would test functional antibody production, by the way, where you would take a baseline blood, vaccinate, and then see whether they can produce antibodies to the things you vaccinated against. Okay? It's not a major.
Vaccinations is
Yeah, no, not those sort of vaccinations, things like Pneumovax or Meningivac, things that don't often aggravate ME, okay? And in that person that I'm talking about that we managed, there was impaired production. And when we started the immunoglobulin, they felt really well. But you'd have to show a defect of functional antibody production.
I have one more question.
Yes.
Please. You mentioned endocrine dysfunction.
Yes.
Or inhibition. You mentioned thyroid. Are there any other systems then that...
Look, I mean, almost certainly, I think that in ME there is abnormalities of the cortisol receptors, okay? We know that certain viruses can increase the cortisol beta receptor, which is non-functional. And so if a virus can increase a decoy receptors, it means you don't respond to your own cortisol. And so your body is not prepared for any stress, as it were. I don't mean mental stress, well, mental stress, but physical stress as well. But trying to do just the straightforward test of cortisol function, like a synacthin, nearly always is normal. Sometimes the morning cortisol levels can be very low, and overall cortisol levels can be low, but when you do the synacthin test, where you stimulate cortisol production, they tend to be normal. And yet we know that long-term stress can blunten this response. And if you treat the people with replacement therapy, they will feel well initially, but as I mentioned, when you continue the therapy, it loses efficacy over a period of a couple of weeks or more, and then you end up escalating the dose and you run into problems. But there is certainly abnormalities of cortisol receptor function, okay? I just wish we could do more work on this. Great. I think it's tea time. Oh, hang on.
One last thing.
Yes.
Just for the lady in front of you that said about the leaky gut syndrome.
Yes.
It's something, I
Yes.
And I cut everything out, gluten, garlic, meat, spices, everything. The thing that was doing it was caffeine. No doctor said that to me at all, like recommended it, or nutritionist recommended cutting that out.
Yeah. And did it help?
Yeah, 100%.
Okay.
I can eat everything now. And there's
That's
no
interesting.
leaky gut or nothing.
I hear what you're saying, and we have previously recommended cutting out caffeine, etc.
Yeah. Just funny that no doctor consultant recommended it to me.
Yeah.
It's only after I found out the caffeine
Okay.
increases gut motility.
Okay.
Which makes sense.
So years ago, I used to recommend what's called a 6-food diet, where you only a 6-food diet, which you have only 6 foods, and you cut out everything. And then, if the symptoms disappear completely, then you introduce 1 food from the restricted list every sort of a week or 2 weeks. But it's a very difficult process.
Yeah.
And
I didn't cut out caffeine, and then later on I felt like enough.
well, in the 6-food diet, you would cut out everything, including caffeine, and then introduce it slowly. So that might have highlighted it then, but it is such a difficult diet to follow.
Yeah.
Yeah.
Freesia, have you heard?
Sorry?
Low dose of Freesia.
Low dose?
Low dose of Freesia. It's kind of like an antibiotic. I understand.
I haven't
My
come
own
across
had
that.
that and seemed to
Yeah.
function very well.
For IBS, I mean, I'm not,
Not for IBS.
No, okay.
For ME. It
For
helped
ME.
to improve.
Oh, okay.
I had to go off it for various reasons, and I've seen a slump.
right.
So,
Well, there is a subgroup of people with ME whose symptoms are made better by certain antibiotics. The most frequent amongst those actually is a penicillin, amoxicillin. And these people, when they're on the amoxicillin, it's a very small number, by the way, they feel really good. And they go back to the GP and say, can I have some more? And the GP says, no. We don't know precisely why that is the case, why they feel better on this. And there's a further small, very small subgroup that feels very well on doxycycline. But again, I mean, with the doxycycline, you can understand it because it sort of inhibits inflammatory cytokine production. But with the penicillin, it's a bit more difficult. But yes, there are people who benefit from certain antibiotics, and we just don't know why.
Sorry, did you mention antihistamines and stuff?
Antihistamines, okay. Then we come on to the issue of mast cell activation syndrome, which is, as an allergist, I would see quite a lot of it. So within the gut particularly, the mast cells can be activated, and trying to restrict certain foods can be helpful in those individuals. To diagnose mast cell activation syndrome, you would need certain urine and blood tests, etc. Okay, and there are very, very few labs that do those tests on the 11-beta hydroxy, those sort of things. But treatment-wise, try loratadine first. You can get that over the counter. It's an antihistamine. On the packet, it says 10 milligrams a day, but as an allergist, we would use up to 8 a day. Yeah, you can try that. Sodium chromoglycate, which is a mast cell stabilizer, or ketotifen, which is an antihistamine and a mast cell stabilizer that can be helpful. Brilliant. Thank you very much.